So my talk is a very quick talk on focus update on antiplatelet therapy. And you can see that the antiplatelet therapy acts partly through the coagulation cascade. You have the prothrombin-thrombin cascade on one side and the platelet cascade on the other. And through various mechanisms, the various drugs act on various of their receptors and create the blocking of the platelet function. So the treatment of acute coronary syndromes, if I put it, is basically antiplatelet ischemic or anticoagulant therapy in STEMI with thrombolytic or PCI. And the unstable or non-STEMI is antiplatelet, anti-ischemic or anticoagulant therapy with PCI or CABG, which is not done immediately, but after some stabilization. Aspirin has major drawbacks, and these are related to not being very effective, a risk of GI adverse events, allergic reactions, and a lack of response in patients, which is called as aspirin resistant. But still, aspirin is still the most important drug and is usage indefinite for most patients with acute coronary syndromes and with ischemic heart disease. As far as the P2Y12, this is a very busy slide, but these are the receptors where they act. Many of them are irreversible binding, some are reversible binding, and it's important that we know this receptor carefully because the inhibition is partly by the receptor which is very firm and reversible, and sometimes it's irreversible. So the first drug is clopidogrel, came through with the CURE trial, which really looked at placebo with aspirin, versus dual antiplatelet therapy with clopidogrel. And what it showed clearly was that clopidogrel and aspirin, though there was more bleeding, had much better MACE outcomes. So over the years, the clopidogrel story became stronger and stronger, and you had the CURE in 2001, the KARISMA in 2006, and the CLARITY-TIMI in 28, which all showed that clopidogrel as an adjunctive to various scenarios in ACS up to 1 year was important for dual antiplatelet cover. Issues with clopidogrel are that, one, clopidogrel resistance is an issue and stent thrombosis continues to occur. Sure, clopidogrel is a prodrug. It is a short-lived active metabolite, has mild potency, slow onset of action, and large inter-individual variability. These limitations were associated with ischemic syndromes, including stent thrombosis. What about prasugrel? Again, it is a prodrug. It has to go through the liver, and many of the drugs which affect the CYP3A45 will affect the metabolism of P2Y12, and this is important when you use, obviously, a drug which is a prodrug and requires a metabolism in the liver. Now, the first drug amongst those was a Triton TIMI, which showed that in ACS patients, STEMI and non-STEMI, who were planned for a PCI, who were blinded after an angiogram, prasugrel was compared to versus clopidogrel for a duration of 12 months with the primary endpoint of death, MI, and stroke, and a secondary endpoint which included target vessel revascularization. What happened was with this drug, prasugrel was superior in reducing cardiovascular death, MI, and stroke at a risk of bleeding. And this is persistently seen in most trials, that the stronger your antiplatelet therapy, more likely your ischemic events will come down, but your bleeding events will go up. So the issue in this trial was that we had to have an angiogram, so it couldn't be run in an outpatient prior to the angiogram. So prasugrel became an interventional cardiologist drug. So as I said, sharper the knife, the more chance you'll get cut. So the important thing is that bleeding is still an issue as you go up on the drug. But clearly, multiple trials with prasugrel, the ACOST, the Trilogy, showed that prasugrel is not indicated for medical management of ACS, that cannot be given in the ER before the anatomy. It's contraindicated if your age is more than 70, your weight is less than 60 at a previous stroke, because it's more potent and can create bleeding. So the dual antiplatelet therapy has gone through from placebo to aspirin, giving you a 22% reduction of ischemic events, another 20% when you added clopidogrel, another 20% when you added prasugrel, but you can see that the pink points are also going up. So clearly, bleeding goes up as compared to ischemic events coming down. And then came ticagrelol in 2009, and through the Plateau trial, which was published in the New England Journal of Medicine, showed clearly for the first time a drug which did not increase bleeding in terms versus clopidogrel. So clearly, this was the first time you're having a drug which is good, but at the same time, no bleeding in those patients. So ticagrelol is more effective alternative than clopidogrel for continuous prevention of ischemic events and thrombosis and death in the acute and long-term treatment of patients with ACS. That's what the Plateau studied, and it reduces myocardial infarction, reduces mortality, and this is the first antiplatelet therapy which reduced mortality, and that could be partly because of its adenosine effects. And there was no change in overall risk of bleeding. So if you look at these trials, what Triton and Plateau look sort of similar in terms of outcome difference, but you can see the bleeding was more issue with prasugrel than ticagrelol. And I think this is something we should keep in the back of our mind. So we have moved towards dual antiplatelet therapy, aspirin continued, and then you had the second drug, which could be any of these three drugs in patients. Now, do you require 1 year DAPT for everybody? And one glove doesn't fit all. And so we have standard DAPT for 12 months, shorter DAPT for 1 month, 3 months, and 6 months, and prolonged DAPT for 24 and 36 months, which have been used in various studies. So the prolonged DAPT is the Pegasus TIMI with ticagrelol, and the shorter DAPT I'll quickly go through is the Twilight and the TICO trial. And what the Pegasus TIMI said that after 12 months of an MI, if you continue ticagrelol for 1 to 3 years with 90 milligram BD, 60 milligram BD or placebo, and you followed them yearly, what happened was in this trial was that you got events down, you can see clearly, both with 60 and 90 milligram versus placebo. So clearly in a high-risk ACS patients like STEMI, there's a continuing prolonged DAPT may give you an advantage in these group of patients. So addition of ticagrelol at a dose of 90 twice daily or 60 to low-dose aspirin reduces the risk of cardiovascular death, MI, or stroke. But again, we had an increased risk of bleeding among patients who had MI 1 to 3 years earlier. So now the evidence of ticagrelol is now coming into shorter DAPT durations, and this shorter durations could be because of various issues, and we are seeing now a group of studies called the Twilight group of studies which are being studied and reported, which is complex lesions, which is Twilight complex, diabetic patients, which is Twilight diabetes, and the TICO trial, all having quite close to 3,000 patients in most of these trials. So in a high-risk group of patients, aspirin alone on a long-term, ticagrelol with aspirin alone in high-risk patients, that was a Twilight trial. And what it showed is in this design that you use ticagrelol and aspirin for high-risk patients for the first 3 months of the enrollment, and then you move to either a combination of ticagrelol with placebo, and then you observe the patients for another 3 months of care. And again, what happened was clearly that keeping ticagrelol alone and dropping aspirin for the first time showed that the primary endpoints of bleeding was lower when you gave only ticagrelol rather than 2 drugs. And so what really happens is, does the ischemic events go up? The answer is no. The ischemic events are pretty much the same. So the bleeding reduced, ischemic events remain okay. So maybe ticagrelol alone is fine. Similarly, in the diabetic group, the same results. The bleeding was much lesser in the diabetic group when you gave only ticagrelol as compared to the cardiac events, or the MACE events did not change when you gave only ticagrelol in diabetic patients. And similarly in the complex trial. So the move was to drop the aspirin after the first 3 months and get the same ischemic advantage with lower bleeding advantages. So the TICO trial randomized evaluation took in patients with acute coronary syndrome. Now this is the first time you have an ACS group of patients who are being studied. And again, in it showed the same sort of monotherapy advantage of reducing bleeding with no significant ischemic change. So clearly, what we're seeing is that ticagrelor as a single drug may be quite good after the first few months of usage in various groups, including complex patients, diabetic, and ACS patients. And this is clearly to avoid the bleeding advantage. And I think bleeding should not be underestimated. It has the same events like a remyocardial infarction. Now, are there any trials head-to-head of ticagrelor and clostridil? And this was basically the ICER REACT, which put the whole trial thing on its head, because this was the first trial which now showed a prasugrel advantage in cumulative evidence of events with no difference of bleeding. And suddenly you're back on square one, saying that prasugrel may be okay as a drug, just like ticagrelor is. There are many comments, but clearly what we need to understand is these are trials which are well designed, and the advantages of these drugs may be dependent on the entry criteria of many of these studies. And finally, we were part of the MasterDAP trial, which was published recently in the New England Journal of Medicine, which took high bleeding risk patients and looked at the Terumo stent with a short abbreviated dual antiplatelet therapy in the high bleeding risk patients. This was looking at what can we reduce a dual antiplatelet therapy in a HBR patient. And this was the Ultimaster stent was used in this group of patients at high bleeding risk. The high bleeding risk is now a standard criteria. You can use some scores to make it, but clearly these are patients who are routine in our practice, elderly patients who have hematological disorders, anemia, CKD, malignancy, and a precise DAP score of more than 25 who can come into your practice. And what they did was they abbreviated the DAP therapy after 1 month and looked at a group with and without oral anticoagulants and looked at the study with a long-term outcome of 1 year. And this was published in the New England Journal of Medicine, which again the same issue, that the net adverse events were no different between an abbreviated therapy versus a standard DAPT therapy, and the risk of bleeding was much lesser. So clearly, again, we are getting back that you can tailor your patients down with antiplatelet therapy and shorten the antiplatelet therapy. Interestingly, in this group of patients, the drug which was continued was clopidogrel more often than aspirin as the single antiplatelet drug. So when you see a patient, it is now, as I said, one fix all. And what we need to do is the patients, are they older? Do they have bleeding events? Do they have a stroke? What is their presentation? Is it chronic stable angina, ACS? Do they have CKD, diabetes, or heart failure? Do they need oral anticoagulants, say in atrial fibrillation? Or do you have a procedural aspect of going for PCI or CABG before we decide these events? And then you calculate the ischemic versus bleeding risk and then decide what to do. Clearly, what we understand is the bleeding risk is, if you look at the two risks, the bleeding and the ischemic risk is maximum at the time of the procedure and then comes down rapidly in 24 hours, while the bleeding risk is more in the first 24 hours after the procedure. And you can see both dipping down now, and then a persistent ischemic and bleeding risk over 12 months. And you now have to put the patient in which group and then decide what to do. I think risk scores are available. I'm not going to go through it. There's the precise DAP score, the DAP score, and you can put it on your app and decide what to do. So I think today, if you look at, this is a very nice article everybody should read. Last week it came in Neurointervention, which puts this whole story together, which sometimes is confusing. And clearly, before PCI, in patients who are stable, aspirin and clopidogrel is fine. During the PCI, for these stable patients, clopidogrel is 1A, prasugrel and ticagrelor is only 2B, and in high-risk group of patients, ischemic. And after the stable angina, DAPT is standard at 6 months, but extended DAPT can be used for high ischemic with low bleeding risk. But 3 months DAPT and 1 month DAPT is for high bleeding. But remember, the recommendations are lower. When you come to ACS, it is a bit different, and you have a more potent P2Y12 as 1A and not clopidogrel. And then you can use prasugrel, ticagrelol, or clopidogrel. The only group of patients where ticagrelol and prasugrel should not be used is immediately during lysis in a patient with STEMI, where current recommendations don't allow that. But I think there will be data soon on that. And then the DAPT will continue in most patients for 12 months, but an extended DAPT could be in AMI patients like the Pegasus. But you can use a lowered risk of DAPT, a lower time of DAPT, with not much of ischemic risk, especially in the HBR patients. So this is how we are going. And patients who have more bleeding risk, you abbreviate, more ischemic risk, you increase. Tailor your drugs according to the size of the patient, whether he is bleeding, whether he is older, whether he is a stroke, whether they're fragile, and make your decision about these patients. So I think DAPTs today is a double-edged sword. One side, it offers protection from ischemia. Other hand, it increases bleeding. We have to maximize ischemic protection and minimize bleeding, and you should tailor the choice according to various risk scores and the comorbidities of the patient. Thank you very much.